necessarily. I don't know. Look, I think it's a great mistake to try to figure out what devices a market will produce. We're not smart enough to do that. If we were, we'd be central planners. And so
well,
I would say that you want to set up a system under which the right people have the right incentives.
Okay. But let me just say, in this particular thing about insurers contracting selectively, is that the reason the market didn't produce that until about 10 years ago is because the doctors and the hospitals didn't want that. They wanted a kind of insurance where once you were insured, you were free to go to absolutely anyone.
Oh, I understand.
And it was really a political battle to overturn the law against that and to allow people to make choices. And when people wanted to make choices, they started choosing HMOs and preferred provider insurance. That is, arrangements where the insurance premium you paid was linked to the doctors you choose. So if you chose economical doctors, that held down your premium.
But let's keep these things separate.
Okay.
For the great bulk of people, year after year, the costs that they would bear would be of the same order of magnitude as the kind of costs they bear now to buy beer and cigarettes for those who smoke or to engage in recreation, much less than they spend on food, because for decades, total medical care costs were about 4% of income, 4 to 5% of income. And if we separate out these major medical costs, and they too, the total of those would only need to be a few percent of income. What's happened now is that we have an enormously inefficient system with tremendous waste, with the most extraordinary administrative complexity you can imagine. So let's go back. For most people, they ought to engage, they will get their ordinary health care. If you actually look at the facts, they're striking. The difference in the premium you pay for an insurance policy which has a large deductible and an insurance policy which has a small deductible is extremely high. If you buy a policy with a deductible of $3,000 versus a deductible of $100, the difference in premium is almost $3,000.
Sure. Of course, there's a very important reason for that, which is, given a choice, the people who do not expect to go to the doctor this year choose the high deductible and the low premium because they expect to pay just the premium, whereas the people who are sick and expecting to go to the doctor soon, they choose the low deductible. Oh yes, Milton, that's really...
I don't doubt that happens.
Right, that's rational behavior.
Yes, but it's also rational behavior that if I have a low deductible, I will be much less careful, much less careful about how much I spend on medical care than if I have a high deductible.
Okay.
But let me go back to the main point. You were starting to say that given that we have a system in which the employers do it, and I take it also you're taking another conclusion, and that is ruling out the possibility of personal medical IRAs.
Well, I wouldn't rule that out. I'm all in favor of incentives for saving and for responsible behavior and economy, but I want to keep coming back to keep reminding you that most of the costs and the most inflationary element of the costs are in that 70% that goes with the 10% of the people who are really sick.
I don't agree with you that that 70% would not be affected, that the 70% itself would not be very strongly affected.
Okay, let me come back to another aspect of this, which is this a market that can be organized effectively at the level of the individual consumer and on the one hand and the insurance company on the other hand? And I think that for several reasons we need to have some collective functions that are today performed by large employers which needs to be performed by some other agency. Let me just explain here. First, the administrative costs in individual health insurance, because of the marketing, the contracting, everything else, are very high, like 40% of premium.
Not for not for high deductible insurance. I beg your pardon. You keep insisting. You keep adopting the common practice now that unless a person has insurance, he can't get medical care. Now that's nonsense. It depends on the kind of insurance. Most of the people who are uninsured, there's all this talk about 35 million people. Most of them are healthy young people who have decided it isn't worth the cost of getting insured. Now,
Because they know somebody will take care of them if they're seriously ill.
if they're serious. Now, and
Yeah.
I believe that there is a case for requiring everybody to have a major medical insurance
Okay, right.
major. I believe there is a case, just as there's a case for requiring everybody who drives an automobile
Hmm.
to have a liability policy.
Right.
And so I'm not quarreling with that.
Yeah.
And in my favorite arrangement,
Hmm.
it would be required that everybody has a major medical insurance
Okay.
program,
Mhm.
but a very, very high deductible, not 3,000,
Yeah.
but something like 10 or 20,000, or 10% of income,
10%
20% of income,
Mhm.
whichever is lower.
Yeah.
So in some cases it would be 3,000.
Hmm.
Now let's, for a moment,
Mm-hmm.
argue on my grounds rather than yours. Let's just assume that you could have a major medical
Yeah.
program for everybody had a major medical of that
Mhm.
kind.
Yeah.
Now do your arguments have as much cogency?
Well, I think so, because
Why?
well, I'd be worried about two things. One is, okay, we're in a world, we're in a world now where everybody just has major medical insurance. I'm still thinking about the need for some collective action. First of all, insurers are becoming increasingly skilled at charging high premiums to the people who have high medical costs and low premiums to the people who have low costs.
That's right, they should. They should. And
Well, I think
you're
that
not opposed to risk premiums for automobiles. And indeed, we've discovered that we had a national disaster because we don't have risk premiums for deposit insurance.
Well,
Surely risk premiums there's nothing wrong with risk premiums.
Well, I think in the case of health care, that it comes up against a social value that sick people ought to be cared for and that risks ought to be
But
spread.
if you have well, hold on about
Okay.
risks being spread.
Okay.
We have a redistributive income tax system already.
Mhm.
I've always thought it amazing that we should have, first of all, we have a redistributive income tax system so that tax rates go up as incomes go up. And then for each individual separate program, we also have a redistributive thing. Why should we have housing distributed on a progressive
Well, I think
income tax scale?
okay.
Why should we have medical? I don't believe that
Well, let's put it
that
this
the
way.
risks of people, first of all, many illnesses are self-imposed. People who smoke, people who engage in unhealthy habits, and I do not see any case for risk sharing in those cases, except through purchase of insurance, any more than I do in the case of automobiles.
Well,
Should uninsured let's take our automobile owners who are uninsured, who don't insure, should the costs they impose on themselves be risk shared across the public at large?
no, but I think health care is different.
Why?
First, okay, it's
In
fair
fact,
enough.
more people mess up their health in automobile
all right.
accidents
It's
than in
fair-
almost
yeah.
any other way.
All right, it is fair enough to say that a lot of ill health comes from irresponsible behavior and self-inflicted ill health, smoking, lack of exercise, and so forth.
Let alone
but still,
unsafe sex practices.
right, fair enough. On the other hand, it's also true that a lot of ill health comes from involuntary misfortune.
Absolutely.
And I think here we're up against a question of social value. I believe that to the extent that it's involuntary misfortune, there needs to be some way of spreading that risk when the costs get large. That is, that people
But
need
we've already
to be
done that with having assumed major medical insurance.
No, because the major medical insurance you're talking about, if it just works at the individual level, the insurers will skillfully underwrite each person, and they'll look at person A and say, you've had a history of cancer, and so next year we're going to quadruple the premium in your policy. This happens to individuals in small employment groups all the time. In effect, we're going to readjust the premium each year to your expected medical costs in the coming year, so that the risk spreading part of insurance breaks down.
I want to separate issues.
Okay.
So let me go to a more extreme case, which I don't like, but which
Yeah.
would be far better than what we have now. You have universal major medical with the deductibles I've stated, very high, paid for by the federal government.
Well, what bothers me about that is, again, I keep coming back to seeing a regime where the 70% of the dollars are going to be in a, you know, cost uncontained mode because moral hazard will take over. The patient says, I don't care what it costs because I'm insured, and the doctor says, I don't care what it costs because you're insured, and there's no
Those
mechanism to
70%, where
force.
do those 70% come from? They come from cost per bed in hospitals
Right.
going up 26-fold.
Mhm.
And that happens because you have employer-based thing, because you have government assuming responsibility, not simply to pay the insurance premium. See, I would have the medical, major medicals provided by private people, by private insurance companies.
Yeah, not by the government, sure, right.
And you have government providing Medicare and Medicaid now. And those are enormously expensive, much more expensive than they need to be.
Right.
So I'm very dubious of your 70% figure based on a present crazy system.
Well, that is the figure. It's pretty well documented. The Rand Corporation did a health insurance experiment in which they found, for example, that any given year, the 1% of patients who had the highest costs accounted for 28% of the costs.
But take automobile insurance.
Yeah.
The
But this is very
1%.
different. Yeah, but this is very different from automobile insurance.
Why?
Well, for one thing, because when people are seriously ill, let's say they have clogged coronary arteries, there is just no end to what can be done on their behalf, and the costs can become enormous. Or with soft organ
And of
transplants
course,
and
even
all
in
these
a
things now,
major medical
we're
insurance.
talking about many therapies
Of
that
course.
cost $100,000, $200,000, $300,000.
But even on major medical insurance, you ought to have a co-insurance payment, just as
Okay,
you do
right.
on almost anything.
Fine. The problem with that is that of just relying on the co-insurance is that people demand financial protection, so they'll want to have a stop loss, and they'll say, after I've paid $5,000 out of pocket or something like that, let's say 20% of income, then I want a stop loss and I want the insurance to pay all the rest. And I would say the problem is most of the dollars are beyond the stop loss and in the free care zone. And so I think we need to create an insurance mechanism where doctors who practice economically can affiliate with an insurance scheme that can offer people a low premium. And that is a key mechanism in the whole thing.
But you don't have to compel that.
No, I think that a
I'm not
market
objecting
system...
of course,
Yeah,
and I'm
right,
not objecting to that
a market
development.
system would produce that.
I'm not objecting to the emergence of HMOs or hospital insurance. On the contrary.
Yeah.
In fact, back in 1962, when I published Capitalism and Freedom, I made a case that the organized medicine was preventing the efficient organization
Right.
of hospitals.
In fact,
And I think organized medicine was preventing it.
in fact, to this day, was that 62 now? 30 years later, I'm very happy to be able to tell you my students read that in my course, and we talk about that. And I think it was marvelously prescient. You talked about, it made so much sense. It would be like a department store, because of course the individual consumer isn't going to know who's the best ologist that he might need in the middle of the night. So he needs some reputable organization, somebody he can trust, that he can choose ahead of time. And so you'd use the analogy of a department store with their buyers and all that. It makes a lot of sense. You need, today we would call that a multi-specialty group practice.
But why didn't it develop? It didn't develop at that time because of the opposition of the medical monopoly.
Right, exactly.
And I think the right answer would have been to eliminate the medical monopoly.
Right. We're slowly chipping away at that.
You know, I'll tell you something. In my opinion, there's only room for one monopolist at a time. We are chipping away at the medical monopoly by replacing it by a government monopoly. And as between the two monopolies, I'm very uncertain which is worse.
Right.
Because at the moment, because of this chipping away, we seem headed inevitably toward complete socialized medicine. And I think that would be such a disaster for a country like the United States
Sure it would.
that we ought not to rule out the possibility of getting substantial changes like medical IRAs. I understand the difficulty that you tend to get very incremental changes in any system, and that is an incremental change, but a big increment. But let's suppose for a moment that we had the medical IRAs. let's suppose